Hello, Region 11, and welcome to Trauma 2. For those of you who don't know me, my name is Dr. Eddie Markle. I'm the EMS Medical Director here at Advocate Illinois Masonic. Today, we're going to be talking all things trauma. We're going to start off by getting in the right mindset. We're going to follow it up with our revised field triage criteria, and then we'll discuss our new trauma management protocol. I'd highly recommend you guys press pause and review these policies if you have not done so yet. Also, I'd recommend that you grab yourself a coffee because we're going to be spending the next hour and a half together. Not to worry, we're going to have some special guests coming by to help keep things going smoothly. All right, we got a lot of work to do. Let's get into it.
Guys, let's face it, 2020 has been an absolute disaster so far. We had the pandemic, civil unrest, social isolation. If you're a parent, you've been stuck home with your kids, having to homeschool them through this all. It's been tough. Despite all this, you, the providers of Chicago EMS, have done an amazing job. And for this, I thank you. You've shown remarkable resilience, and I can't say how proud I am to be one of the medical directors for this system. In this section of the module, we're going to talk about how to be in the right mindset to take care of patients no matter what. We know at times we're going to be exhausted mentally and physically, we're going to be burnt out, and it's going to be tough to maintain focus. Since we're talking trauma today, we know that an essential component of trauma care is to identify patients who should be transported to a trauma center. The best way to identify patients who should be transported to a trauma center is to have a consistent approach for all your patient encounters. I'm going to provide you guys with 3 strategies for all patient encounters to make sure you're identifying people who should be transported directly to a trauma center. The first is committing to performing a full assessment for all your patients. The second is having a high index of suspicion. And the third is to be aware of your cognitive biases. And now we're going to spend some time digging into each of those 3 concepts. Let's face it, guys. Unless you do a full assessment on your patients, you're going to miss things. And I'm going to say the phrase full assessment in this module over and over. I'm going to sound like a broken record, but at the end of the day, if everyone gets a full assessment, then my work here is done. We're going to have a whole section coming up in this module about how to do the full assessment, but suffice to say, if you don't examine your patients, you're going to miss stuff. Having a high index of suspicion for trauma means asking yourself, could this patient be a trauma patient? Or if they're obviously injured, should I be taking them to a trauma center? Could this person be a trauma patient? What am I talking about? There's a lot of runs with limited historical information or almost no information. Think about the down from the unknown cause. And in these cases, the person will frequently have altered mental status, be minimally or unresponsive, and we're simply not going to know what happened. In these circumstances, we need to always think, could trauma have led to this condition? I'm not saying trauma always led to this condition, but you need to consider it in order to catch it. And how are we going to catch it? We're going to need to do that full assessment that I talked about to discover any significant findings that should alert us that we should be taking this person to a trauma center. So what about the patients who've obviously been injured and you're asking yourself, should I take this person to a trauma center? We're going to discuss the field triage criteria later on in the module, but since we're in the mindset section, I want to talk about the right mindset to approach these situations. The default really should be for an injured person that I'm going to take them to a trauma center unless a careful assessment, application of the field triage criteria, and consultation with online medical control find that it is appropriate to take the person to a comprehensive ED. Essentially, it's asking yourselves, why shouldn't I take this person to a trauma center? As opposed to, why should I take them to a trauma center? All right, if anyone's getting the idea that I'm saying that you should bring every injured person to a trauma center, or every altered mental status or unresponsive person to a trauma center, I am not saying that, so don't get any ideas. Our colleagues at comprehensive emergency departments can do a fine job with minor injuries, but they do not have the resources to deal with serious trauma. If they get a serious trauma patient, they have to transfer these patients out, and that could lead to a delay in definitive care and a worse outcome. And by worse outcome, in some cases, I mean death. What I am saying, though, is that we want to preferentially take injured people to trauma centers. And we're going to talk about this. It's called over triage. And we over triage in order to minimize under triage, which is taking patients with a serious injury to a non-trauma center. I mentioned over triage and under triage, and I want to dig a little bit deeper on those two concepts. Let's start with under triage. Under triage is bringing a person with a serious injury to a non-trauma center. As an EMS system, we want to keep this number as close to zero as possible because it could have devastating consequences to the patient. In order to minimize under triage, we need to over triage patients to trauma centers. What is an over triage patient? An over triage patient is somebody who has been injured who is taken to a trauma center. And after their evaluation is complete, it is found that they did not have a life-threatening injury. And it could only be determined after their evaluation. Is over triage a bad thing? Absolutely not. The American College of Surgeons and our own Chicago trauma surgeons want between 25 to 35% of patients brought to trauma centers to eventually be categorized as being over triaged. To put it another way, that means 1/3 of the people who you trauma bypass to a trauma center will be found not to have a life-threatening injury on the completion of their evaluation. And that's a good thing. It's going to keep down under triage. So remember, at the end of the day, err on bringing the injured patients to a trauma center. So what type of patients are we under triaging to non-trauma centers who are found to have a serious injury and then need to be transferred to a trauma center? We have a lot of data on this, and we see some frequent injury patterns that appear on this list. This list includes pedestrian versus auto, all types of bicycle accidents, scooter and skateboard accidents, occasionally motorcycle accidents, and all types of injuries involving the elderly based on our field triage criteria that's age over 55. So these are some injury patterns that when you see, you need to really be erring on the side of caution over triaging these people to trauma centers. So what is a cognitive bias? There are a lot of really long-winded technical definitions, and I'm going to avoid them at all costs. I think it's the best way for us to think about them as decision-making shortcuts that we've developed. We're called upon to make quick decisions with minimal information, and we make those decisions based on prior experiences. But it's important to remember that sometimes those quick decision-making shortcuts that we've developed could be wrong. So let me give an example of how cognitive bias could affect patient care. So I work at Illinois Masonic, and like most emergency departments in the city of Chicago, we receive a lot of intoxicated patients, especially during summer and baseball season. Sometimes on a Friday or Saturday night, it could be a constant flow of intoxicated patients being brought in. And it's real easy in those cases just to classify the person as just being drunk. But what I know from experience and case review is that somewhere in that just drunk classification, you're going to have people with brain bleeds, people with a serious infection, people with a metabolic derangement. And if you lull yourself into the thinking that they're just drunk and do an exam that is just quick and superficial and not doing your due diligence, you're going to miss some serious cases out there. We need to be aware of our own potential cognitive biases and make sure they're not affecting patient care. I mentioned alcohol a number of times, and what I would urge everybody is that when you're seeing somebody and you're tempted to classify them as just drunk, that's a time where you really need to step back and say, I need to do a good full assessment of this person to make sure that I'm not missing something. Again, I am not saying to bring all people who've consumed alcohol to a trauma center on trauma bypass. I am saying to do a full assessment of your patients, and I'm also saying that alcohol use, either real or perceived, does not exclude a life-threatening injury. So don't fall in the trap of labeling somebody as just drunk and ignoring evidence to the contrary. There are two types of cognitive bias that I want to discuss in the module. The first is ascertainment bias. And this means that your thinking is shaped by prior expectations. In other words, you see what you expect to see. An example of this would be that your dispatch for a homeless person who has a known history of alcohol abuse for down from the unknown cause. You've seen this person 3 times in the past week. And when you arrive, you classify the person as just being drunk. But if you were to do a careful evaluation, you discover that there's a new posterior scalp hematoma and the person has a blown pupil and should be diverted to a trauma center. The second cognitive bias that I want to discuss is called anchoring. Anchoring is prematurely settling on a patient impression based on a few pieces of information and failing to adjust that impression once new information becomes available. Once you form that opinion, you tend to only notice evidence that supports your opinion and ignore the stuff that refutes that opinion. Based on the prior example of the person who was found down from the unknown cause, this would be seeing the beer cans and the smell of alcohol and documenting that and using that as further evidence that you think this person is just intoxicated. And if you were to discover the posterior scalp hematoma, saying, oh, I think it was present there a couple of days ago when you evaluated the patient, despite the fact that it is new. In this section, we're going to be discussing the revised field triage criteria. Everyone should be familiar with the format of the algorithm on the right. We've been using this decision tool for the past 4 years on our injured patients to determine who should be diverted to a level 1 trauma center or a level 1 pediatric trauma center. We have a few new revisions. For step 2, we have a new criteria, that is any trauma injury requiring tourniquet application. For step 3, we have some removals. We've removed speed from auto versus pedestrian/bicyclist, as well as motorcycle crash. And for step 4, we've just added to our pregnancy criteria. We now state that pregnancy greater than 20 weeks should be preferentially transported to a level 1 trauma center with obstetric capabilities. A quick reminder before we move on about how to use the field triage criteria. Steps 1, 2, and 3 are essentially yes/no questions. If you answer yes to any of the step 1, step 2, or step 3 criteria, this is an automatic diversion to a trauma center. However, step 4 criteria, special patient considerations, are not necessarily written in the yes/no format. We'll discuss these criteria in detail in their own section. Step 1 are the physiologic criteria. Patients exhibiting these criteria have a physiologic derangement to their injury and will typically look rather sick. We're still using the Glasgow Coma Scale, systolic blood pressure, and respiratory rate to determine the physiologic criteria, and we have made no changes to the criteria. Because of this, I'm not going to discuss them in great detail, but rest assured they will be on your quiz, so I would be very familiar with them. I would like to discuss one of the physiologic criteria in particular, the Glasgow Coma Scale. This is the one criteria that is often left out of telemetry reports, and we frequently have to ask for them. So remember, whenever you're calling in an injured patient, to calculate a Glasgow Coma Scale. Regarding the calculation of a Glasgow Coma Scale, you have to have an organized approach in order to do it reliably. I'll admit, it took me several years because I think I had a mental block concerning this scale to do it reliably. So I'm going to share with you the approach that I've settled on, and hopefully it will help a few of you out there. Whenever I calculate a Glasgow Coma Scale score, I always use the same approach. In my head, I think E4, V5, M6. And this reminds me that there are 4 points for eyes, 5 points for verbal, and 6 points for motor. I remind myself that the lowest you get is a 3, and the most anyone can get is a 15. I've circled the areas of the Glasgow Coma Scale and the image to the right that show where I think we have the most opportunity for improvement. Because remember, it is essential we get an accurate Glasgow Coma Scale score to determine if somebody should be diverted to a trauma center. A few words on the pediatric Glasgow Coma Scale score. While we don't see a lot of pediatric trauma, it is essential that we do calculate a Glasgow Coma Scale score on these patients as well. The good news is there's no change in eyes or motor from the adults. However, verbal is where there are some differences. The way I like to think about it is that If a child is crying, they automatically are getting points off. If they're crying but consolable, they get 1 point off. If they're inconsolably crying, they get 2 off. And if you get 2 off, that means you're at a 13, and you should be diverting that patient to a level 1 pediatric trauma center. In this section, we're going to be doing a deep dive into the Step 2 criteria with Dr. Andy Dennis. Before we get started, I just wanted to give everyone a reminder of what the Step 2 criteria are in our flowchart, and also to remind people that we do have a new criteria, any traumatic injury requiring tourniquet application. And one final thing before we bring on Dr. Dennis. Remember that pelvic fractures are a Step 2 criteria. I just wanted to give everyone a visualization of what the pelvis looks like in all its glory with all the blood vessels that run through there. Dr. Dennis and I will discuss pelvic fractures and the bleeding that could occur with them. I think it really helps to see an image, to see just how many blood vessels run through the pelvis and to appreciate just why there could be such serious hemorrhage associated with pelvic fractures. All right, guys, we're going to talk about our Step 2 criteria, the anatomy of injury. And we have a special guest today, Dr. Andrew Dennis from Cook County. Andrew, tell us a little bit about yourself.
Hey, good morning, everybody. My name is Andrew Dennis. I'm the Division Chair of Pre-Hospital and Emergency Traumatology at the county. I know most of you, or a lot of you. My background is actually all pre-hospital. I came out of the streets in Newark, New Jersey, Philadelphia, and Kansas City. And I worked, like I said, I worked my way through med school as a cop and a paramedic. So this is near and dear to my heart. And working at the county, obviously, for the last 20 years, what we do in the pre-hospital world in Chicago is extremely important to us as well. So thanks for having me.
Yeah, thanks again, Andy. So some people are thinking, why do we need to do a deep dive into the Step 2 criteria? Because on the face of it, a lot of this stuff sounds pretty obvious. We're not going to discuss the obvious aspects of Step 2 necessarily. We want to talk about as more of the subtle aspects of it, how to make sure that we're catching people with some of these serious injuries that need to go to trauma centers. So let's just dive in. So the first one is that all penetrating injuries to the head, neck, torso, and extremities proximal to the elbow or knee. And you're thinking, all right, how are we missing these? So for example, if you get stabbed by something like this, if I give my guy here a stab, it's going to be really obvious that this person was stabbed by a large object. However, if I stab with a shish kebab skewer right through the heart, Dr. Dennis, this could be just as devastating, although the external manifestations of the trauma will be pretty minimal, right?
Yeah. So a couple of things. Let's just back up one quick second. The American College of Surgeons accepts a 25% over triage rate for trauma. So the first thing I want to emphasize to everybody is, when in doubt, you take them to a trauma center. Period. The end. No trauma center should be giving you any grief for taking that patient there. We can always downgrade a patient, but we'd rather have them at the top end and recognize that we have something more serious going on. So we'll take the over triage without a question. When it comes to the penetrating injury, and Eddie, you're totally spot on, right? So what you see on the outside is highly non-reflective of what goes on the inside. And two things I really want to emphasize is, one is that when you're talking about stab wounds, you have no idea what the actual depth is. If it violates the skin, that's for us to just figure out actually the depth and what's at risk. For the pre-hospital setting is, if it violates the skin, period, if it looks like it violates the skin, period, it is a trauma patient and it's penetrating. It's, you know, I know that in the pre-hospital world, you're working in tough circumstances and just in imperfect light, under stressful circumstances. You're never going to have the opportunities to explore the wounds like we do. So again, the depth is unknown if it's a stab wound, period, the end. It should go to a trauma center. As far as gunshot wounds, we really discourage everybody from talking about entrance and exit wounds. And I know sometimes the medics will come in and will say, oh, there's only one hole, so it has to be an entrance wound. Actually, frequently we miss second holes, especially in bigger people. You know, second holes hide a lot. So from a legal perspective and from a safety perspective, a hole is a hole is a hole. A gunshot wound is a gunshot wound. It's not an entrance. It's not an exit. You just don't know. None of us are forensic scientists. And not only for the patient care issues, do I ask you that you not classify them as entrance and exits, but also from a legal perspective, should you get called into court, you don't want to be put to task on forensics that you may not have the answers to. And then when it comes to graze wounds, the same thing. More often than not, what we get reports of as graze wounds are actually penetrating holes, and they're just subtle. So we ask that we don't use the word graze wound. We just say it's a gunshot injury, and let us, under more controlled circumstances with light and instruments, figure out actually if it violates the dermis or not.
Great. Let's move on to chest wall instability or deformity, example, flail chest. And that flail chest injury is going to be a really rare diagnosis to make in the pre-hospital setting. And just so everyone remembers, this is you have a segment of rib that there's been rib fractures and it's no longer attached to the chest wall. So when you breathe, that as opposed to the chest wall going up, that segment goes in. And this is going to be very rare. So, don't think just because they don't have flail chest, just because you don't see flail chest doesn't mean they don't meet this criteria. That, as I started with here, it's really about, that secondary survey. I always like to give compression this way, noting whether or not there's any pain or, I feel any movement at all. But, Andy, these things too, again, just because it's not the really obvious deformity, you can still have some pretty devastating thoracic injuries, even without a flailed chest or a really obvious deformity, correct?
Yeah, when you're talking about the torso, especially belly and chest, you're talking about black boxes, right? You don't know what's going on the inside. For chest walls and for chest injuries, it's a lot about the kinematics, the energy that the person takes the hit with. But more importantly, again, it goes back to the over triage issue. We'd much rather have you over triage a patient with thoracic injury than under triage. Physical exam is helpful, but a lot of times these patients are not going to be reliable to a physical exam. So again, can you trust the fact that they have pain or they don't have pain? Are they intoxicated? Are they not intoxicated? There are a lot of confounding factors that are associated in the field that limit your physical exam. And the chest wall, the chest is just that. It's a black box. You can tear your aorta, and if you're still alive and you tore your aorta, then time is of the essence, and getting the person to the right place at the right time is extremely important. Pulmonary contusions, bad lung contusions take days to blossom, usually 48 hours when they get the worst. Again, you'd rather be in a trauma center than on the medicine service in some peripheral hospital where you're being undertreated. So again, blood in the chest, air in the chest, all those things are very subtle, very difficult to pick up on physical exam. The flailed chest, that's the easy one, right? I mean, that's the one that's going to be, the chest can be moving opposite, what you see when they breathe. But it's all the other subtleties that truly can be life-threatening, and those are the ones that should be upgraded sooner than later.
All right, next up we have kind of similar to two more proximal long bone fractures. We totally get it that you don't have x-ray or x-ray vision in the pre-hospital setting. But again, secondary survey, feeling on there. Sometimes you could have the really obvious angulated fracture there, but again, it could be more subtle sometimes too.
Sure, and remember, pain from fractures comes when bone touches bone. Nature wants to splint those fractures. So what nature does is it spasms the muscles in the extremity in order to limit mobilization. That's what your body is trained to do without thinking, right? But the subtleties of it are shortening of the limb, muscle spasm. Those are the typical telltales that you have an underlying fracture that are often that are only going to be caught with a good physical exam. Make sure you obviously check for a radial or distal pulse. Again, limited pulse exam, typically the vessels can spasm when the fracture occurs in the area of the fracture, so you may have a compromised neurovascular exam. All those things should contribute to upgrading to a trauma center.
Absolutely. I mean, the next one, I'm not sure we need to discuss that much. Crushed, degloved, mangled, or pulseless extremities. If you see it, take it to the trauma center. Don't overthink it.
If it's crushed, degloved, mangled, or pulseless, it should just go to a trauma center. Yes.
Yeah. Then the amputation or partial amputation proximal to the wrist or ankle. I think that from my perspective, if it's a finger or a toe, it doesn't need to go to a trauma center. But once you're getting close to that risk and it's partial or a complete amputation, then it is a trauma center.
Yeah, and usually, and the reason for that is A, there's often bleeding associated with it. B, it's multi-system, right? The definition of wanting to be in trauma centers, there's multi-system injury, and multi-system at a proximal amputation is going to be vascular, orthopedic, and function as well. So, and neurological. So when you put those three things together, that becomes a multi-system injury. And then, again, you can have the later sequelae of amputations that are reperfusion injury, aside from the repair. These things are often far more complicated than a single toe, obviously, or a finger or something like that. So yeah, of course.
All right, now we have a new criteria. It's any traumatic injury requiring tourniquet application. And to the field, remember we just had on the last module, we did have some direction as far as bleeding control. And remember, it goes pressure, then pressure dressing, then finally, if that doesn't work, tourniquet. If obviously you come on and there's horrific bleeding, then you could go directly to a tourniquet. But this is one of the it should be pretty obvious. Dr. Dennis, any subtleties you'd like to mention on this?
Bleeding needs to be stopped, period, the end, because nobody should ever die from extremity hemorrhage. So keep that in mind. And none of us will ever fault you for taking extreme measures to stop bleeding. That said, we do want you to escalate, because shutting down the artery is the last bastion of the form. That is the ultimate, is putting the tourniquet on. But there are other things that you can do that often work quite effectively, and pressure dressing is one of them. A well-applied pressure dressing will stop a significant majority of bleeding. And if that doesn't work, then it'll certainly slow the bleeding. And if that doesn't work, you can certainly escalate to a tourniquet. But remember, the tourniquet is a valve. You're shutting off the valve above the injury. And that's important, and it should be done without question. But, but again, if that goes on, then the signal to the hospital is you have significant bleeding, you're a healthcare provider, and you felt that the only way to control it was with a tourniquet. Therefore, that definitely requires an upgrade to a trauma center.
Pelvic fractures. So what you're examining, you kind of just shake all around and seeing, does it hurt? No, you don't do that, everybody. Remember, when you approach somebody initially too, if you want to feel for any instability, it's really just gentle pressure on those iliac wings. If there's any give at all, you stop, you're done. You assume they have an unstable pelvic fracture. And Dr. Dennis, pelvic fractures are, from a trauma surgeon, pretty scary, right?
Pelvic fractures are probably the scariest thing, but that was really creepy, just saying. Pelvic fractures are probably the scariest thing that trauma surgeons have to deal with. They are typically, so let's back up. When patients are systemically injured, they are already coagulopathic, which means that they're not effectively clotting. So the other problem with the pelvic, so that's you're automatically behind the 8 ball on any bad bleeding. When you break the pelvis, remember the pelvis bone or pelvic bones are a bunch of bones that are fused together. They're highly vascularized. The bones itself carry a tremendous amount of blood vessels, A. B, there's a whole network of blood vessels, arteries, and veins that lie inside the pelvis in front of the sacrum on the back side of the pelvis, and they extend all throughout. And they arborize, or like trees, to an extraordinarily extensive network. When you break the bones, not only do you bleed from the bones, and remember, when you're bleeding from inside the bones, there's no way to put pressure on them, because those vessels are actually inside the bones, and they're not amenable to collapse, because they're stented open by the cannulization of the bone, the tunnels in the bone. So that's one problem. 2, you're already not making clots. 3, it's very hard to apply pressure down deep in the pelvis. And 85% of pelvic bleeding is actually venous. But the problem is, and we know that venous bleeding stops pressure, but you can't get pressure down to the pelvis. So when you examine the pelvis, as you said, any obvious instability clearly should send a red flag up and say, emergency. And the pelvis is one of those places, I always teach, where can you bleed to death? It's floor with the floor, chest, belly, preperitoneum, retroperitoneum, behind the abdomen. and the pelvis, and then the floor. The pelvis is one of those places you can put your entire blood volume very quickly. And it's not surgically amenable to actually stopping that bleeding. So the trick with pelvis fractures, honestly, is recognize that there's pelvic trauma, recognize that you're already behind the eight ball, recognize that you're going to be cold and coagulopathic before you get to any hospital, and recognize that they need to get to a trauma center, and you want to get to a trauma center as quickly as possible.
Yeah. This is a patient population that could be in that talking then die in front of you classification. Really could be some really scary stuff, these pelvic fractures. So as Dr. Dennis said, get them to the trauma center quickly, high index of suspicion.
Right, and then that's exactly right. They frequently are talking, and then all of a sudden they fall off the cliff.
Yeah.
And the problem is, for the trauma surgeon, if you open their belly and you try to fix the pelvis, you're releasing whatever tamponade they have.
Mm-hmm.
So, and there's no effective way to actually stop bleeding the pelvis, because it's usually lots of small vessels and they're already coagulopathic. By the time I've operated on them, or I get them to the operating room, they've already put 3 to 4 liters of blood into their pelvis.
Mm.
And so the answer is resuscitation. Correct their coagulopathy as quickly as possible. And the only place you can be able to do that is a trauma center, because they're the only places equipped to offer massive transfusion that quickly.
Got it. Next, open or depressed skull fracture. Again, this is a pretty obvious one as well. You see it, take it to the trauma center.
If the head is not round, take them to the trauma center.
I love it. And finally, motor or sensory deficits compatible with cord damage. I think we're really good at picking up the motor, the motor deficit. You know, you have one side, you can't move it. That's pretty obvious. There's an injury, take them to a trauma center. Sometimes you can have, the sensory is a bit more subjective. So make sure you're also asking the patient about sensory, and just, you know, can you move your hands? Can you move your feet? Can you feel me touch you? Hands and the extremities. Because the sensory deficit could be the first thing you're seeing as a sign of cord damage. And you want to make sure these patients are going to a trauma center too, right?
Yeah, 100%. I mean, the confounding issues in the field are, first off, that most of these patients are distracted from something else, right? And if you can't feel your feet, you're already distracted. Like, that's panic. You're panicked. If they're awake enough to even answer those questions. So I think the catch-all for this is, if there's any subjective or objective data that's being presented to you from the patient, that he or she has a sensory or a motor deficit, then that person needs to be considered to have a spinal injury, and they need to be boarded and collared and upgraded to a trauma center.
That's great. We've got through them all, Dr. Dennis. We appreciate your time today. We know you're a busy person. Thanks for stopping by. In this section, we will be doing a deep dive into the Step 3 criteria with Dr. Richard Fantis. As I mentioned earlier, there are changes with the Step 3 criteria. You'll notice that for auto versus pedestrian/bicyclist, there is no longer a speed associated with this criteria. And motorcycle crash no longer has a speed. Dr. Fantis and I will discuss the reasoning behind this. During Dr. Fantis and I's discussion, we'll be using a few anatomic terms to describe injuries, and I want to make sure that everyone is on the same page for our discussion. One of the terms we'll be using is an aortic transection. An aortic transection is when the aorta tears or ruptures due to a major traumatic injury. I've included diagrams of the aorta for everyone's visualization. Remember, it is the main blood vessel that comes directly off the heart that supplies blood to the entire body. As you can all imagine, if the aorta transects, it is disastrous to the patient. Another piece of anatomy for our upcoming discussion is the spleen. The spleen is a lymphatic organ that resides in the left upper quadrant of the abdomen. While the spleen is a valuable organ, it filters the blood and provides immunologic function. When we're discussing trauma, the spleen essentially has one point. It bleeds into the belly and potentially kills the patient. All right. We are honored today to be joined by Dr. Richard Fantis. Dr. Fantis, thanks so much for joining us to impart some knowledge on us.
Thanks for the invite.
Absolutely. Tell us, you've been in the system for a really long time, and I've worked with you for over a decade, but just give us a little bit of your background.
All right. Well, yes, I've been in the system for quite some time. I came as the first full-time trauma director to Illinois Masonic shortly after the trauma system started in Chicago, and have been there ever since and seen the evolution and improvement in trauma care, not only from the field, but in the hospital setting as well. Currently, I'm chair of surgery at Advocate Illinois Masonic Medical Center and still medical director of trauma and surgical services.
Yeah, we've worked together closely for at least a decade, and we meet monthly too, every month to review trauma cases. And one of the central things that we talk about each month is we look at our trauma transfers. When our EMS providers take somebody to a non-trauma center, then we receive them as a transfer. We've been looking at those now for quite some time, and I think it's fair to say we've found some themes in people who are taken to a non-trauma center who could have benefited from an initial transport to a trauma center, right?
Absolutely. I think it's been helpful. It's been a practice we've done for quite some time. The goal of any trauma system is really to get the right patient to the right place in the right time. And in order to do that, it's important that there is some degree of over triage, because you do not want to miss that patient who should have gone directly to a trauma center. So we all understand there'll be patients transported to a trauma center that may be questionable, but nobody at the trauma center should question anyone's judgment in the field. You have a small amount of time to make an assessment. We have all the time in the world once they arrive and all the diagnostic equipment. The key, though, is to have a high index of suspicion, and those that may be borderline or questionable, they need to go to a trauma center to err on the side of the patient in order to be able to provide the right care in the right amount of time.
Yeah, absolutely. And, in this section, we're talking about this step 3 criteria. And I would say that the overarching theme of a lot of our meetings is like, oh man, this could have been step 3 criteria. So we're going to be talking about, we've modified a few of the step 3 criteria. We'll be talking about that. We'll be doing a deep dive into just each of the step 3 criteria, because I think that's one opportunity we have to improve our system. One quick thing too, we're talking about mechanism of injury, and a lot of this is, looking at what happened, and it's also getting information as well from people on scene. One thing I just want to say out of the gate is that sometimes with EMS, we're getting handoff from an engine company who's already initially taking care of the patient. It's really essential to make sure you're getting that transfer of information to know what the true mechanism of injury is, because sometimes as a provider who's going to be transporting, you won't actually see the audio, you won't actually see the damage. So it's really essential that you get that information to make sure you can relay that and make the best decision for the patient.
And it just doesn't come down to speed. It comes down to size of vehicle, direction of impact. You may not have all that information. Prior to airbags, people looked a lot worse at lower speeds. So they had facial trauma, some other evidence. Now with airbags, you've lost all that. You may have a little powder burn, but they have a transected aorta, but they look great because they don't have the external signs of the trauma from when they used to hit the steering wheel.
Yeah, great points. Great points. Let's dig into the details of the actual field triage criteria. So the first on the list is the falls. The absolute, you have to bring them to a trauma center, is the adult fall greater than 20 feet. And 20 feet, it's a long way, right?
Absolutely. I have a ranch house, and back in the day, I have a 24-foot extension ladder. So it goes up about 20 feet. And when you're up there, it looks okay, but falling down from there, not good. Fortunately, I didn't fall. The ladder sits in the garage. I'll never do that again. Having seen people of all ages along my years that have fallen from various heights, all types of ladders that are 6 foot, 8 foot A-frame ladders. They end up standing on the top because they don't read the warning labels on the side, don't go above the second step from the top. They have had significant injuries from just 6 feet. It depends what you fall on. If you fall on concrete, it's going to be worse. If you fall, we've had people fall off a one-story building, they hit the banister that happens to be below, and they break their back and sustain other injuries, splenic injury. So 20 feet is an enormous height to fall unprotected unless you're, a stunt person and you're falling into one of those balloons that dissipate the energy you have, because you're decelerating when you hit the ground. And the harder the ground, the more you decelerate and more internal organ injury potential you have. So I would ask anybody to go up 20 feet on a ladder, look down and see if they'd like to just free fall from there. And I would venture to say even on a 10-foot ladder, it's still a significant height.
Yeah.
So these are only numbers on a page. And again, as you have mentioned, it's important to make an assessment and, of the patient and see if there are any cutaneous manifestations that are obvious, any deformities, but you can have significant hidden injury even from lower heights.
One just final word on the falls too. You mentioned, always be aware of that person who's found near the bottom of stairs with some altered mental status. The assumption is they fell down those stairs. So again, make that good assessment, err on the side of bringing them to a trauma center. Next up on children, I know we don't take care of children at Masonic, but as written on the paper, it's a fall greater than 10 feet or 2 to 3 times the child's height. The point I want to emphasize is that when a child is born, the average height or say length of a newborn is between like 18 and 22 inches. Remember, that could be a fall onto a wooden floor off of a changing table. So the smaller you are, the less height you need to have significant injury. Just make sure you're doing a good assessment of how high they actually fell from. And again, err on the side of bring them to a level 1 pediatric trauma center in the case of children. But we'll talk more about that in an upcoming section. Onto the high risk crash criteria for autos. We've already talked about that, and I know the system, we've had this for a while now. Everyone knows about the intrusion in the vehicle, the ejection, the death in the same compartment. I know you've hit on a couple of things just about the high risk auto crash. Anything else you'd like to add, or think we're good?
I think, when you have an auto crash, let's say somebody drives into a building, not uncommon, or a light pole jumps out in front of them at the last minute. The car hits the pole, the driver hits the car, and then the organs inside the patient hit the sternum or other bony objects. So you have 3 collisions that occur in any of these vehicle crashes. So I think understanding that it doesn't need to be an 80-mile-an-hour crash. It doesn't have to be a car that the front and rear bumpers meet in the middle. You can have significant injury transmitted through those 3 stages to your internal organs, specifically abdominal, with spleen or liver that need to be concerned about. So we look at, nobody's going to go out there with a ruler. They're going to eyeball it. Again, these are only numbers. We're not going yardstick, ruler, tape measure. High index of suspicion, err on the side of patients as far as transporting to a trauma center. When in doubt, shout it out, trauma center.
Nice. Next up, so here's one of the changes we have in the system. It's the auto versus pedestrian or bicyclist thrown, run over, or with significant impact. So the changes, there's no longer any speed listed on here. We've removed the speed. For the reason was you really can't get a great assessment of speed in a lot of these situations. And, you think about the transfer of kinetic energy, you have a several 1,000-pound piece of metal colliding with the human body. The human body is typically not the winner in these circumstances. So, you and I have reviewed so many cases over the years of, people hit by autos, and the bicyclists, my gosh, it's just all forms. The bike path is a real source of our traumas during the summer, of people just bike on bike or bicycle just falling onto the pavement, because they go fast now. A lot of these bicycles move really fast, and now we have e-bikes and all these various these devices. There are the scooters. We have these things moving, and in these cases, we've removed speed. A lot, the default in these people, these injuries, really should be going to a trauma center.
Yeah, and if for those of you who ride, I haven't ridden for a year or so, but if you once you get up to 20 miles an hour, and I'll have to admit it, I was going downhill on a grade, and I don't pedal quite that fast. But if you are at 20 miles an hour, which is the old one, and run into anything, that's significant. Anything even 10 miles an hour. So it's really hard to quantify when you're on the bicyclist speed of the impact or a vehicle going through, but there is no protection at any speed, even if they just lumber towards you. So that's why, as Eddie pointed out, the mass of what hits you it's magnified. Imagine standing and having a telephone pole rammed into your chest at 30 miles an hour. Just boom, that would be similar to what would happen as a pedestrian hit by a vehicle. We've had transected aortas over the years in pedestrians. There's no good speed for that, but there have been cases of pedestrians that have been hit, an acceleration injury, transect the aorta. Obviously, bones don't withstand it well either. So we have noticed over the years in our review that several of these patients who've gone elsewhere, they may have not met whatever criteria in the past, have had significant injuries requiring emergent operative intervention after they've been transferred here. Some did better than others, but due to a time difference from being transferred and then coming over versus coming straight. And as we mentioned at the beginning, we want to get the right person to the right place in the right amount of time in the first time. So that's why we looked at these critically and took away some of these confounding aspects of the triage criteria, which made it harder for all of you in the field to try and figure out, did they meet it because, how many miles an hour was it? Or, were they run over and nobody witnessed it? So we're here to protect the patient and get them to the right place in the right amount of time. Doing that, understanding that as the premise, no one at any trauma center should give you any grief for bringing any patient in that meets any of these criteria or less than these criteria, because you're trying to do your job to get the patient to the right place in order to get the best outcome.
Yeah, thanks for that. And finally, we had a motorcycle crash. There was a speed on there, and for all the reasons that you just mentioned, we removed that. And let's face it, once you respond to the scene of a motorcycle crash or two, these are going to be pretty obviously trauma center patients. So the motorcycle accidents don't go well.
Even if they ditch a bike at whatever speed, they end up having significant road rash that usually exceeds whatever a comprehensive ED can take care of. There's just the wound component of that is significant. So that way you don't have to worry how fast were they going. Oh, they slowed down, they ditched the bike. You don't have to do a crime scene investigation. We're trying to make it easy on all of you, so you can bring us the patients we need to see and not put the burden on you in the field to try and make these determinations in a short period of time. You have the least amount of information. The scenes are varied depending on what you roll up on. So we're trying to make it easier for all of you.
Yeah, great. Well, Dr. Fantis, really appreciate you coming and talking about the Step 3 criteria. Thank you for your time. And I think we'll see you in the next section on a few of the Step 4.
All right, sounds good. Thank you very much for inviting me. And everyone stay safe.
We are now going to discuss and review the Step 4 criteria, special considerations. As I have previously mentioned, the Step 4 criteria are not the yes-no format that we see in steps 1 through 3. Rather, step 4 criteria help us identify patient populations that are particularly vulnerable to the effects of traumatic injury. They also provide us with destination guidance for children, burn victims, and pregnant patients who are injured.
All right, everyone, we're back with Dr. Richard Fanches. Again, we're going to talk about the first of these step 4 criteria, the older adults. And when you look at this, as I mentioned in the intro, these are not yes or no's. What these criteria are really doing is trying to alert us that this is a population that is really vulnerable to some bad outcomes from seemingly minor injuries. You know, one of the things is saying that the low impact mechanism, the ground level fall, can result in significant injury. And we've seen this time and time again. I can't say how surprised I've been by what the mechanism of injury described for somebody who is, you know, at advanced age, how just a fall out of a wheelchair and hitting their head, somehow or another they have a brain bleed. I'm like, oh gosh, really? But it really, what it's done is reviewing these trauma cases over the years, especially for older adults, has made me appreciate just how vulnerable this population is to injury, with seemingly minor injuries as well. What do you think, Dr. Fanches?
All right, so now I know why you invited me along to talk about this as being an older adult. So it's near and dear to me now that I'm on this end, looking at it from a different perspective. But having gotten to this point over the years, you're absolutely correct. As one ages, their physiologic reserves are less. They usually have comorbidities. They may be on medications that may mask some of the usual signs. They may be on a beta blocker, other medications. And the blood pressure criteria, we studied the National Trauma Data Bank for years of elderly patient and outcome, and there's a significant increase in death at below 110 systolic. So they're not used to running pressures lower than that. They had an increase in mortality when they arrived below 110. So that's a specific trigger for the elderly population. And as on this piece of paper, death increases as you get older. That's logical. But as pointed out, the mechanism, it doesn't take as much. Ribs are brittle, bones are brittle. We've had people trip on the street, mechanical, not even a sinkable fall over, end up having a brain bleed, as pointed out, and they end up progressing and dying. We've seen people that had a same level fall, getting out of the shower or whatever, end up with cervical fractures, intact in the field, and some remained that way, others did not. So it is paramount to understand we have an aging population, and trauma in an aging population, the vital signs and the mechanisms are different. So you need to have even a higher index of suspicion for lower mechanisms of trauma and lower alterations in their physiology to bring them to a trauma center.
Yeah, I think it's important to point out too is that outcomes for elderly trauma patients are better at trauma centers than compared at non-trauma centers. Isn't that correct?
Yes, it is, because as we've learned over probably the last decade, there are certain treatment algorithms that need to be in place for geriatric trauma, if we want to label what it is. It involves more than just getting the patient to the right place in the right amount of time. There's a whole host of things that need to go on in the hospital, at the trauma center, that go through the spectrum from resuscitation, therapeutic intervention, convalescence and then discharge either to a home or rehab facility. They have unique requirements that need to be factored in: speech, swallowing, various levels of physical therapy. So you need a whole host of people and a game plan when you're talking about geriatric trauma patients.
Yeah, I think it behooves us to say that just because you're over 55 or older and you have any type of injury, that doesn't automatically mean you take everyone to a trauma center. But as you mentioned, you need to have a very high index of suspicion, do a great assessment on the patient, find any areas of pain, any potential injuries, and relay that at online medical control. Sometimes, the person will be found that it'd be okay to take them to a non-trauma center, but that's really only after a great assessment, consultation with online medical control, and then after that's been determined, then if it sounds really, really benign, then sure, they can go to a non-trauma center. But you're right, we really have to have a very high index of suspicion for our elderly population. All right, everybody. Now we're talking about pediatric trauma. And just to give everyone a reminder of what we mean by pediatric trauma, I like to think of it really simply. It's the driver's license test. That if you could get a driver's license, you should be going to a level 1 trauma center. If you can't get a driver's license, you should be going to a level 1 pediatric trauma center. And if anyone forgot what the age of driver's license is, it is 16 years old. So 16 and above, level 1. 15 and below, you go to a pediatric level 1. So we're really blessed today to be accompanied by some of our pediatric trauma experts in the city of Chicago. Guys, you want to introduce yourselves?
Sure. I'm Rashmi Cabray. I'm a pediatric surgeon at Lurie Children's Hospital and also trauma director at Lurie Children's.
And I'm Corinne Sadecki-Lund. I am the trauma coordinator at Lurie Children's.
Guys, thank you so much for coming on and talking with us. You guys deal with a patient population that scares most of us daily, and we thank you so much for the work that you do. And remember, everybody, we're talking to Lurie's today, but we have 3 level 1 pediatric trauma centers in the city of Chicago. We have Lurie's, we have Comer's at University of Chicago, and we also have Cook County at Stroger Hospital, Stroger Cook County. So we have 3 level 1 pediatric trauma centers available to us. So that's a great resource. No other part of the state has a resource like that. So it's really fortunate for us and for our pediatric patients that we have this available. So guys, what does a level 1 pediatric trauma center offer that a regular level 1 doesn't offer?
Well, I think a lot of it has to do with the fact that we have a lot of ancillary staff that is all pediatric related. So we're talking about pediatrics IR, pediatrics radiology, pediatrics ENT, peds ortho, peds CV surgery. And a lot of these are just specific to pediatrics. So we don't have to transfer anything out, which is, I think, the key difference as opposed to a level 1 center that doesn't have a lot of these capabilities.
And additionally, I'd just like to add that we also have some of these resources that our patients need, like protective services team or social work, and that can really help our patient population and their families.
Yeah, I work at a level 1 trauma center, and I could just say that level 1s within the city of Chicago, we don't have those resources that you guys have, that you guys offer our injured pediatric patients. If we get a patient who's injured at my hospital, we have to stabilize and transfer. So I think it's essential that everyone remember that the way it's written, it's in our rules, it's like injured pediatric patients should preferentially go to a level 1 pediatric trauma center if within 25 minutes. Some may ask, why 25 minutes? That is an IDPH rule right there. So that's really inflexible. We have to follow the IDPH standards for that. But if you're within 25 minutes of a level 1 pediatric trauma center, you really have to try to get those injured children to those centers. And it's interesting because the sicker they are, they actually need to really go to a level 1 pediatric trauma center even more. We're not asking anyone to do anything you're not comfortable with, but the child may look bad. You try to get them there. You call online medical control. You discuss the case. We do it on a case-by-case decision to try to make sure we're doing the right thing for the patients, balancing that out. Because if they stop off at that level 1, like I say, we're going to stabilize. We are not going to provide definitive care. We're then going to have to transfer it there. So just remember that. Always call on online medical control for these cases, discuss it, and we try to get all our injured children to level 1 pediatric trauma centers.
Yeah, I think we really tried to hone that in 2012 when I took over this position, mainly because I noticed that so many places were going to an intermediate hospital before coming to us. And we really try to get trauma patients in general. Remember, we have that golden hour where we'd like ideally kids to get to the fastest place, as soon as possible, but to the correct place that they need to go to for definitive management. And by and large, majority of kids are pretty stable. Very rarely do you have life-threatening injuries in kids. It tends to be more blunt trauma than penetrating. And bottom line is that golden hour is key. And if you can get that kid to the appropriate center within that hour, it's the best care that you're going to get for them, rather than wasting time, wasting money for the family, and wasting radiation. A lot of times these kids get excess radiation that they shouldn't be getting until they get to that definitive center.
Absolutely.
And sometimes goes both ways. Sometimes you can get too many x-rays, and sometimes you don't get the right x-rays, or the x-rays that they do get are not great.
Right. Any cases that you'd like to share, or maybe just some common injury themes that you're seeing now, who are injured kids who are brought to a non-trauma center and then have to be transferred to Lurie's? Anything you guys like to share with us?
So we have a couple cases, actually. One of the kids had a distracting open tib fib fracture, and I think everybody honed in on the fracture. He was hit by a car. He did have some other injuries, and they treated it more or less like a isolated ortho injury. And we forget the fact that he was hit by a car coming home from school, and we get focused on the open fracture and how horrible it looks, and his foot is facing the wrong way. And we kind of forget the overall big picture of getting injured by getting hit by a car.
So a lot of these kids may have polytrauma. They may have, facial fractures, head injuries. And luckily we have all these people on staff. We have, peds ortho, peds plastics, as well as child protective services, availability 24/7. So I think that's the key thing, is that we don't have to transfer kids out.
Yeah, I know that Dr. Fantis and I, earlier in the module, we discussed the pedestrian versus the auto. Children are just as vulnerable. They're not, you get hit by a car. We discussed at length that human body versus several thousand pounds of metal, the outcome is not good for the human body. So great example there about looking at that distracting injury and honing in on it and forgetting that, as you said, Dr. Cabre, it's a polytrauma. It's not just the obvious that you're seeing. It's more, it sometimes could be the things you're not seeing visually that are going on inside that could really be the potential for the disastrous outcome.
Yeah, the past few months has really brought in a lot of bicycle injuries, that just with everyone on bicycles, and more so even with kids. And, what we used to see is less injurious patients that weren't as injured, that didn't require an operation. But what we've seen recently is a lot more, blunt injury from a bicycle handlebars, or flipping over the bicycle handlebars. And these kids come in needing an operation, whether it's because of a bowel. We've had two, I think, that have had a bowel injury that was either delayed diagnosis, or it just wasn't clearly seen on imaging. And so a lot of times it takes that extra eye to just observe the kid overnight, that inpatient hospital stay. I mean, we have a PICU, NICU inpatient team 24/7. And I think that's key, to be able to observe these patients, even though they may not have anything completely obvious on initial survey.
And now that everybody's bored in their house, they're doing more crazy TikToks and doing, stuff that is kind of risky. And we're doing super flips on the trampoline and getting some pretty bad injuries from trampolines, backyard equipment. We're seeing an increase of dog bites that are pretty severe too. So
we've seen some of those too. They could be really horrific. And just because it's a bite, it's the teeth on some of these larger dogs to do the jaws very powerful, do some serious damage.
Yeah, it's a perfect height for the face for those younger kids. So it's typically always the face.
Yeah, yeah. Well, guys, let's summarize. I mean, basically, if you are 15 and younger in the city of Chicago and you get injured, preferentially you should go to a level 1 pediatric trauma center, unless it's that 25-minute rule we talked about there. But as we discussed throughout the whole module, high index of suspicion, good assessment, and err on the side of a trauma center. There are no changes to the anticoagulant and bleeding disorder criteria. Overall, I think we're doing a really good job of identifying people who take anticoagulants or have a bleeding disorder and relaying that information when calling a telemetry report. In the special consideration, it specifically mentions head injuries, but really any type of traumatic injury could be devastating to a person if you have a bleeding disorder or are taking an anticoagulant. So it's important to get that information and to relay it when calling a base station to determine if it would be most appropriate for this person to be transported to a trauma center. I'm including a list of some of the more common anticoagulants that you're likely to encounter. This is not an exhaustive list, so remember, you have to ask specifically if somebody takes an anticoagulant. I'd recommend everyone pause for a moment and review the names of these medications that you're likely to encounter, because you will likely encounter them at the end of the module when you take your quiz. While anticoagulant medications receive most of the attention for this special consideration, it is important to remember that there are bleeding disorders that we also need to identify. Hemophilia and von Willebrand disease are two of the more common bleeding disorders that you may encounter. If the patient is altered or unconscious, be sure to look for a medical alert bracelet, because this may alert you that the patient has one of these conditions. For patients who have experienced burns, there is no change to this special consideration. A patient who has burns and any of the other listed trauma criteria should be transported to a trauma center. Burns without trauma should be transported to the closest comprehensive emergency department. There is a change to the special consideration for pregnant women greater than 20 weeks who are injured. St. Francis in Evanston no longer has obstetric capabilities. Because of this, we revised this special consideration to state that we should preferentially transport injured women with pregnancy greater than 20 weeks to a level 1 with obstetric capabilities. Currently, St. Francis in Evanston is the only level 1 trauma center that does not have obstetric capabilities. All right, guys, we have one final special consideration, and that is one of the most important. That is paramedic judgment. And who better than to talk to us about that is Chief Mary Sheridan from Chicago Fire Department. Chief Sheridan, tell us a little bit about your impression of how valuable the paramedic judgment is on determining whether or not somebody should come to a trauma center.
Well, I think it's very valuable, particularly in the category 3 or the step 3 or the step 4 of the physiologic criteria. Step 1, it's obvious. Step 2, it's fairly obvious. But when you get to the step 3 or the special considerations, it's very important. The paramedics actually see the damage to the vehicle. They are able to estimate the height of the fall. They are speaking to witnesses. They're speaking to everybody at the scene that might contribute a piece of the puzzle to the determination of what the mechanism of injury was. And I think that the paramedics have to trust their experience, trust their judgment. And if they get that impression that this is a trauma case, maybe it doesn't fit neatly into one of the criteria, but their judgment is valuable. They should request transport to a trauma center and push that issue. I don't think they're going to get any feedback or blowback, whatever.
Yeah, absolutely. We've talked to Dr. Dennis, we talked to Dr. Fantis, and unified that the theme is that if you suspect bring them to a trauma center. There should be absolutely no pushback at all. If you're erring on the side of doing the right thing for the patient, that should never be an issue.
I think we're fortunate that we have a wealth of trauma centers at our disposal, including the suburban ones we transport to, and having the 3 pediatric facilities that seem to be well distributed throughout the city. There are instances where a child may not be able to be transported to the closest pediatric trauma facility, but in virtually all cases, I believe that the pediatric trauma should be directed to the pediatric facilities.
Yeah, no question, no question. Chief Sheridan, thanks so much for. You guys have had to hear me say the word assessment again and again and again. In this section of the module, we're going to talk about what the expectations are in Region 11 for a trauma assessment. And we'll be using, for the guideline, the General Trauma Management Protocol. This is attached in your Target Solutions assignment. I'd urge everyone to take a moment to pause and review the General Trauma Management Protocol, because it'll help better follow along with the discussion that we're about to have. As far as what's contained in here, most of you are doing these practices every day already, and what this provides is a framework to organize how you approach every trauma patient, first starting with the primary assessment and then moving to the secondary assessment. We have 4 goals for the General Trauma Management Policy. First is to provide rapid assessment and management of life-threatening injuries. The primary concerns for assessment and management of the trauma patient are major hemorrhage control, maintaining the airway, oxygenation and ventilation, maintaining perfusion, and neurologic function. The second goal is to identify patients who should receive trauma bypass. We just spent a considerable period of time discussing the field triage criteria. You're going to be using your assessment and applying those criteria to identify patients who should receive trauma bypass. The third goal is safe movement of patients to prevent worsening of injury severity. You might want to brush up on the spinal motion restriction policy that recently came out. And finally, rapid and safe transport to the appropriate trauma center. So how do we stay alive? I'm going to offer a simple explanation which will demonstrate why the primary survey is so important. Basically, we have red blood cells. Those red blood cells get oxygen, and then they deliver that oxygen to other parts of our body. Trauma disrupts that normal process, and the primary survey serves to try to correct that disruption. The goal of the primary survey is to rapidly identify any life threats in a stepwise fashion and to treat those life threats. As I mentioned with my example about staying alive, we want to try to keep the blood in the body and to maintain that blood's oxygenation to keep the patient alive until you could deliver them to definitive care at a level 1 trauma center. The primary survey needs to be conducted the same way every time in a stepwise fashion. You'll notice by looking at our policy that there's now hemorrhage control before airway. A good way to think about this is to remember X, A, B, C, D, E, X for exsanguination to help you remember hemorrhage control. We have to make sure that we address any problems that we encounter at each step before moving on to the next one. We're now going to look at each step in detail. I've enlisted some help to help me demonstrate the steps of the primary survey. First is X, preventing exsanguination or hemorrhage control. We're not talking about minor bleeding in this step. We're talking about severe, life-threatening hemorrhage. And this is going to be fairly obvious on somebody. There's going to be blood everywhere. Because the bleeding will be so severe, if the bleeding is coming from an extremity source, we should just be placing a tourniquet immediately. Or in the case of a junctional wound in either the axilla, the armpit, or in the groin, We could use either hemostatic gauze or regular gauze and direct pressure. We need to try to achieve hemorrhage control before moving on to the next step. This keeps in step with what I mentioned as far as how we stay alive. We're trying to keep the red blood cells in the body. For those of you who have transported a patient to a trauma center, you've undoubtedly been met by doctors asking the patient, "What's your name?" We're not actually that interested in what the patient's name is. We're performing the airway assessment of the primary survey. If we hear a nice clear response from the patient, we say airways patent and we move on to the next step, breathing. If we don't get an answer from the patient, we know we have to evaluate the airway. Simultaneously during this step, we're also initiating spinal motion restriction, primarily in the form of no unnecessary movements of the neck until we could apply a cervical collar. So how do we assess the airway? So if we don't get a response, we look to see what's happening. We look for any kind of facial injuries. We look for any expanding hematomas to see if there's blood or vomit. And we go ahead and open the airway. We could do a jaw thrust, that way avoiding any unnecessary movement at the spine, and look in to see what's going on. If we see there's pooling secretions, blood, or vomit, we'll perform suctioning of the patient's airway. I don't have any suction in my house for demonstrative purposes. If the patient is unable to maintain their airway, then we know we need to maintain that airway for them. We have our airway adjuncts. I have an oral airway here that can be placed if appropriate. And if they're not maintaining the airway, we also know that we're going to need to start breathing for them likely. So we'll have our bag valve mask handy. Other ways to maintain the airway would be with a supraglottic airway. Here's our iGel that hopefully you've all been trained on by now. We can place this on the patient and start breathing for the patient while maintaining that airway. To my example of how we stay alive, we're making sure by having an open airway that we're able to deliver oxygen to the red blood cells. After we've completed our airway assessment, we then move on to the breathing. We start off by looking at the patient and evaluating their respiratory rate and pattern. Are they breathing too fast, too slow? Are they in obvious respiratory distress? At the same time, we're looking at the chest and evaluating for symmetry of movement. Are we seeing an obvious deformity, any paradoxical movement? We then move on to assess breath sounds bilaterally, listening laterally. Here we're making note of any diminished or absent breath sounds on either side. During the breathing assessment, if we find that the patient is in respiratory distress, has absent breath sounds on one side, and is showing signs of hyperperfusion or hypotension, we're going to go ahead and perform pleural decompression, which is an angiocath on the side where we do not hear breath sounds. If the patient has an open chest wound, we're going to place a semi-occlusive dressing over the wound or a chest seal. And if appropriate, we can apply oxygen during this stage to the patient. On to circulation. During this step, we're evaluating the patient to see if there's adequate oxygen delivery throughout the body. And we do that through evaluating their circulatory status. During this assessment, we'll evaluate the skin. We're looking at the temperature, color, and moisture. We're checking for capillary refill, and we're also evaluating for peripheral pulses. If we find that the patient has cool, pale skin, is diaphoretic, has a weak, rapid, thready pulse, we know that the patient is not getting adequate perfusion. And we need to ask, what could we potentially do right now to correct this? If we took measures during the first step of the primary survey to get hemorrhage control, we need to make sure those are still working. During the breathing phase, we potentially could have needled tension pneumothorax, which could cause poor perfusion. We need to make sure that was done appropriately and adequately. And then, if we don't see any obvious sign of hemorrhage, the assumption is that the bleeding is internal somewhere. If the bleeding is internal, it is essential that this patient is rapidly transported to a trauma center. There are a few things we can do during the transport to try to improve the situation of poor perfusion. If we know that there is obvious instability of the pelvis, we can place a pelvic binder if available, or use our old friend the sheet in order to try to stabilize the pelvis and prevent further bleeding. Also during the transport, we can start an IV to try to titrate the blood pressure to the parameters that I'll now be showing you in order to maintain the patient's perfusion. You'll notice that our new fluid resuscitation guidelines are a bit more detailed than we currently offer. I'd also like to point out that we have a new guideline for patients who've suffered a head injury. We want to maintain their systolic blood pressure from between 110 to 120. For these patients, it's essential that they do not get hypotension because this can worsen their outcomes. I'd also like to note that for patients who do not need fluids, it is still appropriate to have a keep open rate to ensure you have patency of the IV that you've started. For disability, we are going to start by evaluating the person's GCS. Hello, can you open your eyes? No response, a 1 for eye opening. I hear no sounds at all. There's been no verbal response, so there's also a 1 for verbal. With stimuli, I'm seeing no motor response at all, so also a 1 for motor. I have a GCS of 3. If the person were awake and able to follow commands, I would ask him to move his arms and legs for a quick motor assessment. This is also the time where we should be evaluating for any signs of brain herniation in people with TBIs. We do an assessment of the pupils, looking for any unequal pupils. We also are looking for any signs of posturing that we already evaluated using our GCS. If we find signs of a traumatic brain injury during our disability assessment, remember from circulation that I mentioned for people with traumatic brain injury, we should be targeting the systolic blood pressure from between 110 to 120. You're now going to perform a rapid assessment of the patient's entire body, looking for any obvious penetrating or blunt injuries. You really need to look under the clothes. I'm going to leave the mannequin's pants on for now. And at this stage, you're going to roll the patient too to check the back. There's only one of you right now, so doing spinal motion restrictions, protecting that C-spine is essentially impossible, but let's take a look in the back, making sure there's nothing obvious back there. It is during this stage too that if there's wet clothing, you're going to remove that wet clothing, and you also need to make sure you're keeping the patient warm, so place a covering quickly over the patient. Well, we made it through the primary survey. But remember, one of the themes of the new protocol is frequent reassessment. So if you notice a status change on the patient, you could run through the primary survey really quickly again to see if there's a particular system that needs immediate attention. If there is, intervene, stabilize, and continue on to a trauma center. You'll all be happy to know that you are not going to have to suffer through me performing a secondary survey on our mannequin back there. However, it is the expectation that you all are performing the secondary survey as explained in our new protocol on all injured patients. You're going to start by obtaining historical information. You could use that historical information about the injury to determine whether or not this person could qualify for Step 3 criteria. You'll get their medication history and their past medical history to determine whether or not the person has a potential Step 4 criteria, bleeding disorder or anticoagulant use. The exam of the secondary survey is a head-to-toe assessment of the patient, looking, listening if appropriate, and feeling to determine whether or not there are any injuries that weren't identified in the primary survey or any areas of pain. You're going to use this information and ask yourself, do my findings mean this person meets step 2 criteria? And you're also going to use these findings when you're contacting online medical control to help make the best determination whether or not this patient should be diverted to a trauma center. And remember, I noted it's feeling as well. You need to palpate along the patient to make sure that you are identifying areas of pain. Just asking the person if they have pain in an area doesn't count.
As we mentioned before, sometimes the step 2 criteria can be really obvious, but other times it's more subtle and you need to do a good physical exam in order to pick up these findings. As I said, I promised I wasn't going to do the entire secondary survey. What I'd like to do now is share some physical exam tips to help find some people who should qualify for step 2 criteria. We all know about the step 2 criteria, open and depressed skull fracture, but it's equally as important to identify any contusions or injuries on the patient's head. In particular, I want to point out if there's swelling to the left or right temporal region that I'm highlighting right now, this could be a sign that the patient has an intracranial bleed, specifically an epidural hematoma. These patients will typically present talking with a GCS of 14 or 15, and then will rapidly decompensate. What's happening is that bleed in the brain is rapidly expanding and compressing the brain. For these patients, it's essential to get them to a level 1 trauma center as quickly as possible to get the urgent surgical intervention they need. For our patient, I'm not noting any chest wall instability or deformity, but the exam doesn't stop there. I'm looking to see how the chest wall is moving. I'm looking for any bruising, specifically if it was a motor vehicle collision. Is there a seatbelt sign on the patient? And I'm also palpating all around the chest, looking for any areas of pain on the patient. It's not the chest wall that I'm worried about. A rib fracture is painful. What I'm really worried about is what is going on inside the thoracic cavity. Is there an injury to the lungs or the structures in the mediastinum, specifically that aorta in the mediastinum? Injuries such as pneumothoraces, hemothoraces, aortic transections, these injuries can be devastating to the patient, and one of the clues to identify them will be that exam, looking for the bruising and noting any pain. I'd like to mention a few points specifically about the abdominal exam. It is very important to do a thorough exam of the abdomen. As I mentioned, the chest, you have to look for any bruising. You have to also palpate the entire abdomen, noting any points of tenderness. I mentioned earlier about the spleen. The spleen resides in the left upper quadrant. If you palpate the left upper quadrant and the patient has pain, you should be thinking, could this person have a splenic injury? If there's pain in the right upper quadrant, you should be thinking, do they have a liver injury? These large intra-abdominal organs, when injured during a trauma, could start bleeding into the abdomen. At first, the patient will look stable, and they can decompensate very quickly. So it's essential to note these physical exam findings and make sure you're taking the person to the right destination.
Let's finish up this section on general trauma management with some of the special considerations that are mentioned in the new protocol. For any exposed intra-abdominal organs, you're going to cover them with a saline-soaked dressing and then place an occlusive dry or plastic dressing over that. For pregnant patients greater than 20 weeks gestation, we're going to elevate the right side 15 degrees in order to take any pressure off the great vessels and prevent hypotension. When evaluating a patient for potential traumatic arrest, the first step is to look for any signs of life, pulse, breathing, or spontaneous movements. If you find no signs of life, the next step is to apply a cardiac monitor. If you find a systole on the monitor, resuscitation can be withheld. However, any other rhythm besides a systole means you should start resuscitating the patient immediately and begin transport to a trauma center. We want to try to minimize our scene time with trauma patients to less than 10 minutes. This is especially important for people who are unstable and likely to need a surgical intervention. Reassessment of the trauma patient as well as any other critically ill patient, is essential. This module should have taught everybody that the trauma patient could decompensate suddenly. If there's a sudden change in status, we need to run through that primary survey again to see if there's a particular system that needs to be addressed. All right, guys, it's been a long one. Let's close out this module. First off, we used a different format this module. It's primarily videos. We really want to know what your opinion of this new format is. Please contact your resource hospitals with your feedback so we can make future modules best suited for your educational needs. To remind everyone, we do have a few revisions to our field triage criteria. For step 2, we now have a criteria that any traumatic injury requiring tourniquet application should go to a trauma center. For step 3, we've removed speed from the auto versus pedestrian/bicyclist and the motorcycle crash criteria. And for step 4, we've added that for pregnant women greater than 20 weeks, they should be preferentially transported to a level 1 trauma center with obstetric capabilities. In addition to the revisions to the field triage criteria, we also have our new trauma management protocol, which outlines what we mean when we say do a good trauma assessment. In closing, when you come upon an injured person, remember to ask yourself the question, why shouldn't I take this person to a trauma center, as opposed to why should I take them there? Sometimes trauma is really obvious in the case of the gunshot wounds and the stabbings and the high-speed MVCs, but other times it's much more benign in appearance. It's the older person who falls and hits their head with a GCS of 14. It's the bicyclist who was hit by an auto who was just complaining of some flank pain. The outcome for these cases, the less impressive cases though, can be devastating if you don't take this person to a trauma center. So remember, it's essential to have a high index of suspicion, to do a good assessment, and err on the side of trauma center. Guys, thanks for your attention today. Stay safe out there.